Hello and good evening, good day to everyone. I'm very happy to be back once again with all of you. It's our time. It's time for our IVF webinar. So I hope you are having a fantastic day so far. And I'm very excited to be back once again because this is a topic I definitely am looking forward to hear. And of course, as you can see, we do have another special guest. This is Dr. Melvin Thornton, and he is the reproductive endocrinologist at Global Fertility and Genetics. And he will be presenting tonight from New York City. So hello, Dr. Melvin. How are you feeling tonight? Hope you are good.
I'm feeling amazing. I'm happy to be here.
And we are definitely happy that you are here indeed. And thank you so much for agreeing to present this particular topic tonight for us. And as you can see, our topic is fertility preservation for male patients. So of course, Dr. Melvin will explain everything on that particular topic to all of you. But afterwards, as always, don't hesitate. Just go ahead and type the questions that you might have. And I'm sure Dr. Melvin will be happy to help you out with those. And well, as you know, my IVF Ancestors is a part of European Fertility Society. And we are here every single day simply because we want to support you. We want to give you the chance to ask your questions. And as you know, there are plenty of fertility specialists, coaches, but also yoga teachers even, just to help you out, just to answer your questions. And also we just want to make sure that you have a place to come and feel that you are not on your own. So no matter at which part of your fertility journey you are, we just want to make sure that you are definitely well taken care of course, wherever you are going ahead with your treatment. So that will be it from me. And of course, right now, Dr. Melvin will start his presentation. So you can go ahead and share your screen right now, okay? Because I know already that Dr. Melvin has prepared some of the videos. So it's going to be definitely interesting. And I definitely cannot wait. Thank you so much, Dr. Thornton, once again. And go ahead, okay?
Thank you very much. Well, it's a pleasure to be here. And I'm excited to talk to everyone. And soon, once we're back, put the pandemic behind us, we'll be able to meet here in New York. And you guys can remember, if you've been here before, how wonderful New York is. If you've never been in New York City, then after the pandemic, please come by and say hi and join us here in New York. Tonight's topic is going to be about fertility preservation in males, which is a very important topic that usually gets overlooked. And it's an important topic because there are a lot of diseases, malignant as well as benign diseases, that by themselves or with treatment will impair a male's ability to have a baby in the future. So it's really, really important that we preserve this potential of any male to have a child when they're ready to have a child in the future. Now, I put this slide here, even though we're talking about male fertility preservation, because everyone in the world nowadays talks about the female biological clock and female fertility preservation. We all know that women have a biological clock that ticks and their fertility rates decline once they're over 30, particularly over 35. And because of the advent of new technology called vitrification of eggs, you hear about female egg freezing all the time. This is a video, and this just shows the new advances we call vitrification in the egg, where we can collapse the egg and now freeze that egg once it's collapsed. And by doing that, we're able to preserve a woman's eggs so that when we go to thaw them out in the future, she will have the same chance of having a pregnancy that she would at the age that she froze the eggs. So that's the latest technology for women. And because of this technology, we hear about it every day on the news. There's things that pop up. Egg freezing is such a hot topic. Even Barbie's thinking about freezing her eggs. And then here in New York, there's a lot of articles being written in the New York Post and New York Times that talks about what women can do to maintain their fertility. But what's important is, let's talk about guys, because we don't want to forget guys. Guys have interest in preserving their fertility as well just as women. And it's important because, there's a rumor out there that, men can have children up until the day they die, which is true. However, you do lose sperm cells as we get older. And as we get older, we do have a decrease in our fertility rates. So in men who are delaying their childbearing years, it's important for them to understand this decline and to consider maybe preserving their fertility, or particularly men in clinical situations where they have a genetic disorder, an autoimmune disease, or cancer treatment that can negatively affect the way the sperm is produced. Now, another important aspect about sperm is that for years now, sperm counts in the Western part of the world has been declining. And what you'll see is that you get about a 50% decline from 1973 to 2011. And this decline is anticipated to continue on through until 2045. So because men are naturally having a decline in their sperm counts, it's a very important topic to talk about preserving fertility. And the slide here just kind of demonstrates that there are a lot of things in the environment that's affecting our sperm. So this is looking at the mean sperm concentration and count associated with global plastic production since 1970. So what you'll see is that as the plastic production goes up, the sperm count has gone down. So talking about fertility preservation for men is a very important topic. So what's the bottom line? The bottom line is when we talk about fertility preservation in men, we're talking about freezing sperm. Okay, freezing sperm is the process of collecting, and after we collect it, we got to analyze it to make sure the sperm counts are healthy, and then we store that sperm for later use, and that sperm can be used for later use for fertility treatments such as inseminations or in vitro fertilization. It can be donated to other couples or individuals for their use, and it also can be stored indefinitely. When we talk about sperm cryopreservation, okay, the important thing about sperm is that it's been around. Sperm freezing has been around for many, many decades. Sperm can be stored for indefinitely until it's needed. There's reports of babies being born after men have frozen their sperm for more than 20 years. And there are a lot of new indications now for freezing sperm. One of the indications is an advancing male age. Someone that's known to have a decreasing sperm count or a very poor sperm count, they can freeze their sperm to pool it and bank it to have a better chance of having fertility success with IVF or insemination. We know that when men are diagnosed with certain cancers, that there's a risk to the chemotherapy, radiation therapy that will affect their sperm. And then other things that we forget about, certain lines of work that may be life-threatening and put his fertility at risk. So we also talk about preserving fertility in those men, such as men who are being deployed to a military zone or war zone. They have a high chance of having an injury that could threaten their fertility. There's some men who have decided to have a vasectomy, but in some cases they change their mind after the vasectomy. They say, I want to have more children. So it's always important to consider banking your sperm prior to a vasectomy. And then for transgender patients, we always want to talk about preserving their sperm prior to transitioning. The cryopreservation process involves, number one, being screened routinely for infections such as HIV, hepatitis, and syphilis. The sperm is provided either via masturbation or sperm extraction. Once it's in the laboratory, the lab will examine it for sperm quantity as well as sperm quality. Then we freeze the viable sperm, and then once again, that sperm can be stored indefinitely. Are there risks involved for sperm freezing? And the answer is that sperm freezing has been around for decades. It's successful use since 1953. It's a very safe and standardized process, and it continues to improve as technology advances. There's no risk or side effects to producing sperm naturally because this is typically done by masturbation. If someone's unable to masturbate or they have a medical condition that prevents them from masturbation, then they can use surgical procedures. And these are very small surgical procedures, but there are risks associated with that of bleeding as well as discomfort. And then the most important thing is that cryopreservation sperm has no time limits. You can leave it frozen indefinitely. And like I mentioned before, healthy babies have been born from sperm that's been frozen for more than 20 years. Now, some clarification. There's a lot of confusion that what's sperm and what's semen. So basically, sperm are the male reproductive cells that contain the genetic material, and the semen is the liquid that's ejaculated, and it may or may not contain sperm. So what I mean by that is that when a male ejaculates, you can see sperm cells in the semen. However, there are a lot of men who will produce semen, but they won't have sperm cells inside the semen, and that's called azoospermia or no sperm. One of the biggest topics for male fertility cryopreservation is cancer. And here in the US, 9% of cancer diagnoses are those who are younger than 45. These are men who are in their reproductive age groups. And 1% are found in people who are young men who are under the age of 20. The most important thing about cancer is that cancer survival has improved due to the advances in cancer therapies. And now we talk about the concept of cancer survivorship, which means that most people diagnosed with cancer will have a good outcome with treatment and have a long survivor. So now we're talking about being able to maintain their reproductive potential in the future after they've had treatment. So how does cancer treatment affect sperm and male fertility? Fertility problems in men from cancer or treatment occurs in two ways. Number one, direct damage to the endocrine glands, such as the testicles. You can also damage the thyroid and adrenal glands, which are important for sperm production. You can have damage to the sperm or lower sperm production, lower semen production, as well as damage to the nerves or the ducts that cause ejaculation. When we look at the effects on cancer treatment for men, there's greater effects on fertility if you're using chemo and radiation. The testes and testicles are very sensitive to chemotherapy and radiation therapy. Now, in women, if they get chemotherapy or radiation therapy at a young age, they're typically able to come back. The younger they are, the younger they get the treatment, they're typically able to come back and produce eggs in the future after the treatment. However, in men, young boys, there's no protective effect at a younger age. So no matter what age you get, you treat it with chemotherapy or radiation therapy, there's a greater chance of you ending up with sterility or no sperm in the future, no matter what age you initiate the treatment. It also has a negative effect on sexual function. You can get erectile dysfunction because of damage to the nerves that may occur with some types of cancer surgery, etc. So when we look at the different types of treatment, and chemotherapy, there are things that are called alkylating agents, and these are the most toxic to sperm. They can cause gonadal dysfunction by causing damage to the testicles. They can reduce or stop sperm production. And in fact, when men are treated with these alkylating agents for cancer, they will develop, 80% will develop azoospermia or no sperm post-chemotherapy. And in many cases, this is permanent. There's been some advocates in treatment in the past using something called a GnRH analog to try and suppress sperm formation during the time that you're undergoing chemotherapy, but that's been shown not to be effective in preventing the loss of sperm after chemotherapy. Radiation therapy is, the testicles are very sensitive to radiation therapy. There's something called spermatogonia, which are the precursor cells to mature sperm. And these cells are very sensitive to radiation therapy, particularly when the radiation therapy is targeted towards the testicles, the pelvis, or the pituitary gland, which causes the hormone production to stimulate the testicles to make sperm. When you look at high risk, if you take the dosages, the higher the dosage of the radiation, the more of an effect that you're going to have on the sperm. So in men, if you have greater than 2.5 grays, can lead to azoospermia and nospermia. And in young boys, more than 6 grays can lead to high risk for azoospermia after the treatment. Surgery. Some men have to go through surgery for their cancer, such as testicular surgery or prostate surgery. And this type of surgery on the prostate, bladder, intestines, the spine, or rectum can damage the nerves, which can cause erectile dysfunction and ejaculatory dysfunction. These surgeries can often cause what we call retrograde ejaculation. In other words, instead of ejaculating through the penile urethra, many men, because of the damage to that bladder neck at the penile urethra, will now only be able to ejaculate retrograde into the bladder. An important aspect is that men who are diagnosed with testicular cancer should be offered sperm freezing prior to removing the testicle. Okay, this is important because many times before you remove a testicle, the other testicle may be damaged or may be smaller, and by removing the one testicle, you may be left with no sperm production from the other testicle. So if you're diagnosed with testicular cancer and you're going to have a testicle removed, it's really important that you undergo sperm freezing prior to the orchiectomy or removal of the testicle. This is an example of a normal sperm count that you see here on the left. You'll see there's sperm that's moving and there's some debris here. And this is prior to initiating chemotherapy or radiation therapy. And then here on the right, you're going to see the effects of chemo and radiation therapy on the sperm. You can see the sperm count is much reduced compared to prior to initiating the treatment. So post-radiation and chemotherapy, the sperm may or may not return after treatment. Depends upon the dosages that you were treated with prior to initiating the treatment. However, even if the sperm does return, it's not going to be the same prior to the treatment. If there is a stop in the formation of the sperm, this may last for years. It can even lead to permanent infertility. Risk factors for increased fertility issues are going to be, once again, the higher doses of the radiation or chemotherapy. Some men already have existing fertility issues that will worsen with chemo and radiation therapy. And then increased age. Younger boys who receive treatment may have less sperm damage, but they still may have a long-term effect after treatment. When we look at the treatment with chemo and radiation therapy in a study that was done in the Clinical Journal of Oncology, what they showed was that after chemo and radiation therapy, looking at paternity, 56% of the men treated suffered from lack of paternity. And once again, it was related to the types of chemotherapy, such as alkylating agents, as well as the dosages of the chemotherapy and the radiation. So even without cancer treatment, okay, survivors are less likely to achieve a paternity because of the effect of the cancer on the sperm cells, even without treatment. So this shows the importance of preservation early in the diagnosis of any type of cancer that may affect male fertility. So what are the strategies that are available for fertility preservation in males with cancer? Number one, it's important to counsel all males on the reproductive risk of cancer treatment. You also need to be counseled on the availability of fertility preservation options prior to initiating cancer treatment. And any post-pubertal males should be offered sperm cryopreservation. This is the standard fertility preservation method for men, and it should be performed prior to initiating treatment. And that is the key. It should be performed prior to initiating treatment to give you the best chance of maintaining a male's fertility in the future. Now, one of the big dilemmas is going to be prepubertal males because of the fact that in prepubertal males, they're not producing sperm. So there's research going on to see what we can do to help them maintain their fertility. Nowadays, prepubertal boards offer research techniques where they do a biopsy of the testicle, and that tissue is preserved and potentially reimplanted in the future to produce sperm in a more natural way. Or the stem cells that from the testicular tissue can be used to create sperm cells in the future with stem cell technology. Once again, this is experimental, only done on a research level basis. Another aspect that's concerning for fertility preservation is going to be aging of the male. Aging is one of the leading causes in male infertility, low fertility. As men get older, we have difficulty conceiving. And there's little studies out there to show that for men older than 50, the chance of miscarriage with their partner is early in the early weeks of pregnancy is almost double compared to men who are younger. And then other things as we get older, it causes slow, gradual changes in the reproductive system in a process called andropause. Yes, I'm sure all of you have heard about menopause, but we also can have issues as we get older called andropause. And this is where we get a decrease in our testosterone levels, which leads to a change in testicular tissue production. Erectile dysfunction is also common in this process as well. Now, when you look at paternal aging, we all, like I mentioned in the beginning, we always talk about the effects of age on women. We never talk about the effects of age on men. And what you're going to see in this graph here is that sperm counts have declined over time, as we mentioned before. This is 1975 compared to 2010. And what you see in 1975, the peak male fertility was at age 27. And now, in 2010, the peak age in male fertility is now 5 years later, age 32. But overall, fertility rates quickly drop off after age 33 in men. And now the studies have shown that fertility rates actually peak a little bit later than what they did in the 70s. Now the peak fertility in males is about 32. Other things associated with paternal aging, you have a decrease in testosterone. Older men will experience a decrease in libido, sexual dysfunction, and sexual frequency, which all lead to reduced opportunities for conception. When you look at the data, and in the data, what they do is that they control for the female age. In other words, when you have men, as the male's age advances, but the female age stays the same, when you do studies comparing both, what you'll see is that the rates of pregnancy followed by men over 50 years of age were 23 to 38% lower compared to younger men at the age of 30. Similarly, when they looked at a larger study, and here they had about 93,000 patients, what they found was that there was a statistically significant associated decline in semen volume, sperm motility, sperm progressive motility, the shape of the sperm, and what we call fragmented cells, as well as the concentration, all lead to decrease in fertility as men age. So once again, increase as we get older, there's an increased spontaneous miscarriage rate. In a retrospective study looking at 1,100 IVF cycles where they were doing sampling the embryos to see if the embryos had normal chromosomes, what they found was that in men over the age of 40, there was a lower incidence of normal embryos or euploid embryos compared to men 35 to 40. There's also known to be an increase in DNA fragmentation, which means that the DNA in the sperm cells are damaged, and about 15% increase in highly damaged DNA and about 20% increase in DNA break in the number of sperm from men aged 36 to 57 compared to younger men. We also know that as we get older, we're prone to acquiring what we call DNA mutations. This is typically due to oxidative stress as we get older, as men get older. This increased rate of mutations places the sperm of older men at risk for acquiring mutations that may affect the health or impact health of their offspring. There's a lot of talk about different types of neurocognitive disorders associated with paternal age, and much of the literature that's out there does support a correlation between paternal age and risk of neurocognitive disorders. Some of the hypotheses that explain this increased risk with advanced paternal age is increased frequency of these mutations, like we mentioned before, age-related epigenetic alterations in sperm, selection to late fatherhood, secondary to paternal psychiatric disorders or subclinical predisposition, and environmental characteristics all lead to an increased risk of neurocognitive disorders as a male's age advances. Many times you may hear the term advanced paternal age. Advanced paternal age particularly applies to men who are over 40. Another category where we need to focus on fertility preservation are transgender women. And before transgender women start to transition by using hormonal therapy, this hormonal therapy or long-term estrogen treatment may be associated with testicular damage. And spironolactone, which is also used during the transition phase, is also associated with testicular damage. the best practice is to encourage sperm banking before initiating any type of hormones before a trans feminine individual transitions. So what's involved in fertility preservation or sperm collection? This is an example of a collection room. This is actually one of the nicer collection rooms you'll see. Some places may just be a bathroom, but they try to put a nice quiet area. As you can see, there are magazines to help men produce, their TVs, but nowadays most men will bring in their own phones that has videos that they can access to help them produce a sperm sample. In the room, the male will masturbate to orgasm, and then once they've orgasmed, they'll put it into a special container. This is very important that you use a special container because you want to make sure there's not any toxicity associated in that container. If you're producing a sperm sample, you also want to make sure that you're not using any type of jelly because things like KY jelly can affect the sperm life, can damage the sperm. So if you're going to need some lubricants, the best lubricant to use is going to be mineral oil. The sperm is placed into the specimen cup, and then it's analyzed by the laboratory team. For men who are uncomfortable going to an IVF center or a sperm bank, there are now at-home collections for you to produce at home and send the specimen to the laboratory and have it frozen at the laboratory. So a lot of options out there on how you can go to preserve your fertility. Once the specimen is produced, a small sample of the specimen is looked at under the microscope to make sure that you have a normal concentration, make sure the motility is normal. And when we're talking about normal sperm counts, a normal sperm count should be at least 15 million sperm per ml. We like to see at least 40% movement or motility, what you see here, this forward moving sperm that you see there. And then the shape of the sperm, we like to see at least 4% normal shaped sperm. That all constitutes a very healthy sperm specimen. When you're banking sperm for fertility preservation, oftentimes you'll have to have infectious disease screening. And this is an example of some of the types of infectious disease that you're screening for. Once a specimen is produced and it's been analyzed, we now use what's called cryoprotectants. These are basically materials that will prevent any type of damage from the freezing process. The sperm is now frozen, what we call a slow freeze. It's down to minus 196 degrees Celsius. And then in the future is warmed up to be used either for intra-uterine inseminations or IVF. Now, per ejaculate, per semen sample will contain anywhere between 5 to 20 million sperm per ml. And this can be divided into several vials for storage. Typically, with one semen collection, you may get 2 or 3 vials of sperm that you can freeze. Many times you may be asked to collect more samples than just the one. On average, it's about 2 to 3 times because we want to make sure that you have enough sperm that's banked for future use, either with an IUI process or insemination or with IVF. Now, by collecting more samples, this improves your chances of being able to have a child in the future. And depending upon the quality of the sperm that's being frozen, survival rates run anywhere between 10% to 50%. If someone's strongly affected by their cancer prior to freezing the sperm, or they've been treated with chemotherapy prior to freezing sperm, and the sperm sample is not that great, the survival rates will be closer to 10%. But if someone has a very healthy sperm count and they initiate the cryopreservation before they undergo chemo or radiation therapy, survival rates of the specimen is about 50%. Now, what if a male can't ejaculate or masturbate? Some heterosexual couples may need to have intercourse in order to produce sperm. There are special condoms that you can use during intercourse that collect the semen that can be then frozen. It's important that if you are going to use a collection condom, you use a specific type of condom because any type of materials that are found in a standard condom can cause sperm death. In men who have spinal cord injuries or unable to ejaculate due to stress, anxiety, there are things that are called vibratory ejaculation or electroejaculation to help men produce a sample. And then, as I mentioned previously, there are some types of cancer that damage the nerves. There are some types of surgical procedures that may damage the nerves or damage the area close to the valve at the entrance to the bladder. And this will allow for what's called retrograde ejaculation. So the ejaculatory ducts are damaged. The ejaculation doesn't go through the penis, but goes into the bladder. So then in those cases, we will get a urine sample to remove the sperm and freeze the sperm in that manner. And men who can't produce or have certain special circumstances, we can do surgical extraction. There's a outpatient extraction where you place a needle into the testicle after the testicle's been numbed up. This is called a testicular aspiration. You can aspirate the testicle or the area called the epididymis, or you can go into the OR to take a testicular biopsy to get tissue from the testicle, which can be frozen for future use. So now you've either had a diagnosis of cancer, you had other reasons why you wanted to preserve your fertility, you've gone to the sperm bank, you've gone to the reproductive center, you've frozen your sperm, it's been frozen for as long as you wanted to freeze, and you decided, I'm now ready to start my family building journey, okay? Your future treatment of how we're going to use that sperm depends upon the quality of the sperm that was frozen and the number of vials that were frozen. The two ways that we can help men have children in the future after preserving their fertility is with what's called intra-uterine insemination with the female partner or in vitro fertilization. The success rates of the intra-uterine inseminations and the in vitro fertilization not only depend upon the quality of the sperm, but also depend upon the aspects of the female partner, such as her age, history of miscarriages, or history of previous infertility. So this is the intra-uterine insemination. And so what happens is that when you ejaculate, the sperm is thawed as the semen. And in the semen, you're going to see the sperm that's moving, and there's some debris. In order to use that sperm for an insemination, we have to wash away the debris. So we're left with just a healthy sperm, which you'll see right here. This is sperm that is now increased its motility and is now ready to fertilize an egg. Once that sperm is the process is called sperm washing. Once that sperm is processed and washed, it is now placed into the uterus of the female partner in what's called an intra-uterine insemination. This type of procedure does not require any anesthesia for the female and is pretty much just like a woman having a pap smear, which she has on an annual basis. If the sperm concentration is low or there's not a lot of vials of sperm that were frozen ahead of time, then the female partner will have to undergo in vitro fertilization, or if you're going to be using, if you're single and you're going to be using an egg donor and transferring embryos to a gestational surrogate, the female will undergo in vitro fertilization where she takes injectable medication to make multiple eggs. Those eggs are then retrieved in an outpatient procedure that does require anesthesia. And then once we retrieve those eggs, the sperm is now surrounded. The egg is now surrounded with the sperm and someone that has a healthy sperm count. And those who have very little sperm, we use a procedure that's called intracytoplasmic sperm injection, where we take one individual sperm that you see here, and that sperm is injected directly into the egg. Many programs and that does IVF, when they're using frozen partner sperm or men whose sperm who've been frozen for various reasons, they automatically will do the intracytoplasmic sperm injection to give the sperm the best chance to fertilize the egg. So what you see here is the sperm is here, and then the sperm is now directly injected into the sperm to help the egg fertilize. Once those eggs are fertilized, either with conventional insemination, with the egg is surrounded by the sperm, or injecting the sperm into the egg, we come back to create embryos. And this here is an example of embryos that are created. And then one of these embryos are now transferred to the uterus of the female partner or the gestational carrier to help her conceive. And that is my presentation. I'd be more than happy to take questions at this point in time. So I'm going to stop sharing my screen here and take questions.
And thank you so much indeed for your wonderful presentation. Lots of details, lots of interesting information for sure. Thank you so much. I definitely think it's been very useful to all of you. And now it is time for your questions. There are like 2 questions right now, but of course, if you have any, you know what to do. Just go ahead and type those in. And I'm sure Dr. Thornton will be happy to help you out with some of your questions. So let's start with the first one, okay?
Looking forward to it.
It is. So, do you recommend hormonal treatment before sperm retrieval, TESE, in a man with non-obstructive azoospermia with FSH2 and LH2 and normal testosterone 350 nanograms and estradiol 13?
So that is a very good question. Ooh, I would like to try and say your name, but I'm gonna go by the middle name and say Anna, because the first name, it looks a little tough for me, but maybe Cor. Oh, I can't even try. But thank you for your question. So basically, what the question is asking is someone that has a low sperm count is not due to obstruction. What is the recommended treatment? Okay. So typically, what we try to do as fertility specialists is to see if we can increase the sperm counts on a more natural level. Many times you may have heard of medicines called clomiphene or letrozole, which are typically used for women to increase their egg numbers in a fertility cycle. But we also use the same kind of medications for men to try and increase their sperm counts. So it's not unusual to see a male be placed on clomiphene or be placed on letrozole to try and increase the sperm counts. Now, the most important thing to remember is that in the sperm cycle, it does take 74 days on average to make sperm. So if you're going to initiate that type of treatment, you have to give it at least 3 months and to see if the sperm has improved. If it hasn't improved, in many cases, the reproductive specialist may say, let's go another 3 months to a total of 6 months. And then if there's no improvement in the sperm numbers, then at that point in time, they will have a testicular aspiration or testing procedure.
Wonderful. Thank you so much.
Thank you for the question.
Definitely interesting question. Thank you so much indeed for that, and of course for your excellent explanation to this one as well, and that very detailed question as well. Now we will have another question here from Lisa. Is there a time limit for using the sperm if it's frozen?
Lisa, thank you for your question. There is no time limit. Many case reports have been shown that men have frozen their sperm for over 20 years and they've had healthy babies. So there's no time limit for using the sperm if it's frozen. It's just a matter of choice whenever you're ready to start your family building journey.
Excellent. Thank you so much indeed.
I'm going to add a little bit to that.
Okay, sure.
So medically, there's no time limit. But what's important that I did not mention in the presentation, because most of the people here are from Europe. Here in the U.S., in order to freeze sperm, it may cost about anywhere between $700 to $800. And then on an annual basis, the storage fees may be about $1,000 per year. So sometimes people look at those numbers and they say, okay, well, I do have to put a time limit on how long I'm going to store my sperm just because of the cost. But medically, the sperm can be frozen indefinitely, but there is a cost of storage fees. Some sperm banks will give 3 to 5 years of storage for sometimes $2,000 or $3,000. So all depends upon the sperm bank that you're working with here in the U.S. or in Europe. I imagine everything's much less expensive in Europe. But here in the U.S., it's about $1,000 per year, unless there's special deals they're offering for long-term storage for 3 to 5 years. For sometimes I've seen $2,000, I've seen $3,000 for the store sperm for 3 to 5 years, and those are U.S. dollars.
Amazing. Thank you so much for adding that, because this part is also, of course, interesting to know. Thank you so much indeed. And let's have a look. Okay, more questions are coming up. So there's another one from Biso. What causes DNA fragmentation, and is it curable?
Very good question. Thank you, Biso. What causes DNA fragmentation is typically going to be oxidative stress. Oxidative stress comes from diet. The best way to treat that is with a good male multivitamin or antioxidants or a good diet. A lot of my clients, I will push on fish oil. Fish oil has been shown to decrease DNA fragmentation. Other things that can cause DNA fragmentation are environmental, and then as well as things that we do to ourselves, such as smoking, poor diet. All those things can lead to DNA fragmentation, but it's definitely reversible by using antioxidants.
And excellent. Again, thank you so much for that question. And now we have a follow-up, of course, from our previous patient, from Anna. Let's have a look. But if the report between TE is more than 10, is it necessary, correct, to recommend letrozole?
Let me see if I understand your question. If the is more than 10, is it necessarily correct to recommend? Yeah, it is preference. Here if one medication doesn't work, then they will always go to a different medication. So whichever one you start off with. If you start off with Clomid, then you try that for 3 months. If that doesn't work, then you'll switch over to letrozole unless someone has side effects or they have a contraindication where they can't take letrozole or they can't take clomiphene. So we recommend either one. Depends upon preference, depends upon what you're looking to accomplish as far as side effects, but they're both equally effective as far as improving sperm in men. And the question is, how do you recommend letrozole?
Mm-hmm.
Typically, the dose of, I'll start off with the dose of clomiphene. Most people using clomiphene are taking 25 milligrams every other day, and the dose of letrozole is 5 milligrams every other day as well.
Wonderful, thank you. And one more, okay, from Anna. So above what value of LH or FSH do you recommend injection with gonadotrophin?
Once again, thank you, Anna, for a wonderful question again. Is not a value of FSH or LH. We here in the U.S. tend to start off with the least invasive treatment, which are the oral medications, clomiphene or letrozole, and then move to the more invasive, such as injections with gonadotropins. The problem here in the U.S. is that gonadotropin injection therapy may run about if we're using the gonadotropins, it may run anywhere about $1,000 per device with a pen, and that tends to be very expensive here in the U.S. So we try to start off with the most cost-effective treatment, which is the oral medication. So we don't use it directly. We use it mostly in couples or men who have not had success with the oral medication.
And once again, thank you so much indeed for your follow-ups, Anna, of course, and for explaining all those details. Okay, next question. Another interesting question. Are there any risks involved in freezing sperm?
Thank you for your question, Lisa. There are no risks involved in freezing sperm.
Straightforward question, and of course, forward. Much. And someone is first of all, as you can see, there are some thanks already for answering the question. So this is the great thanks from Biso, but also from Anna. So thank you for the clarification. And let's give it a second. Someone is again typing, so I just want to make sure whether it's another thank you or if it's a question. So if you do have any questions, of course, go ahead, type those in right now, and we just need to wait a minute for some more.
Well, this is very exciting because a lot of good questions are coming through.
Yep.
Anna has very, very good questions, and Anna in clinical medicine is based upon a lot of different things that you have to look at the individual, and I know some doctors just have a standard approach they use for everyone, but the way I see patients and recommendations to clients is that all individual. And, some treatments that are appropriate for one individual may not be appropriate to work for the other individual. So it's always based upon an individual presentation and individual results.
Thank you so much for adding that. And actually, in the meantime, I know why we needed to wait a bit for the question, because it's a bit of a longer question. Okay, so let's have a look. We had one round of egg retrieval in Ukraine for a donor, and we winded up with 1 healthy embryo out of 7 blastocysts. Second round of stimulating a different donor, we winded up with 5 healthy embryos out of 9 blastocysts. What could be the problem? First donor was 24 and out of Ukraine. Second stimulation was done in Georgia, and second donor was 30 years old in Georgia.
Okay. So I'm looking at the question here. You got 7 blasts. So when you say healthy, are these embryos that were tested for chromosomes or PGTA? Is my question that I see. So I would say in the first scenario, okay, great, thank you. So I would say in the first scenario, the fact that you had a much better response to the second egg donor, I would say there may have been an egg issue with the first egg donor. So I would say, I would imagine if the first one could have been an egg issues, particularly if you had the same sperm with a different egg donor and got much better quality embryos, 5 out of 9. Statistically, just so you know, in nature, 50% of fertilized embryos or fertilized eggs will become a blastocyst. And of those, 25% will lead to a healthy blastocyst. So it all depends upon how many eggs you're starting off with, how many fertilize, then you'll see how many develop. And then looking at the individual age of the egg donor, someone 30 and below, you'd expect to have at least anywhere between 30 to 40% abnormality rates. That's what the data shows. So with your second donor, you had a really, really good outcome.
Wonderful, thank you. And let me just show you, okay? Yeah, around 1820 for both egg donors. Yep. This is the follow-up. Okay, thank you so much indeed for your advice. A bit of a off topic, but of course we don't mind that at all, right? So let's have a look.
Very good.
Let's have a look.
Sometimes just to follow up for BESO is that also depends upon the stimulation. You can have a donor that has better quality eggs in one cycle compared to another cycle. So there are a lot of different factors that go into play. But the biggest thing that you demonstrated was, I'm assuming that this is the same sperm that you use for different egg donors. So by using a different egg donor, having a better outcome, I would say the sperm is definitely not the issue. But for the first egg donor, it could have been the eggs for that cycle.
All right. And BESO has just confirmed, yeah, same sperm. So
yep.
That would sum it up then. Thank you so much. And let's have a look, okay? Anne has added one more thing. What contraindication are for letrozole administration?
Good question. Contraindications for letrozole. It's very minimal contraindications for letrozole. I'm trying to think of one that jumped off the mind, but there's more contraindications with clomiphene than you'll see with letrozole, because letrozole has the effect on the brain. So if anyone has a history of migraines, anyone have a history of visual disturbances, you will stay away from clomiphene because that can affect those organs with you using clomiphene. But for letrozole, there's really no contraindication for letrozole, unless, of course, they've had an allergic reaction to it the first time they took it, or side effects that were unbearable the first time that they took it. But there's nothing as far as contraindications that stand out.
Perfect. Once again, thanks a lot for that. And there's, of course, thank you from BESO for your great, thank you. And Lisa has also added this question: could sperm DNA undergo impairment through in vitro handling after collection?
Could sperm DNA undergo impairment through in vitro handling after collection? Typically not, because the way the sperm is processed, you're washing away the sperm that has that's poor quality, so you're left with a better quality sperm. There are new devices that are out there to separate the sperm a little bit better. There's something called a zymote. That's new technology where it's only the sperm that have normal heads and normal tails can actually swim through. So you're selecting out the sperm that are damaged with DNA, fragmented DNA. But this routine handling of the sperm during the IVF process does not cause DNA impairment.
All right. Thank you so much for yet another explanation, of course, to this question. And we will be slowly finishing. Okay, so if you have any questions left, this will be like your final call. So go ahead and type those in. And Anna has added one more question. So, in your opinion, letrozole should be recommended in all men with non-obstructive azoospermia?
Yes, I believe it's a good option to use letrozole or the clomiphene. I don't have an issue with having everyone take letrozole. I think it's a good drug. It's very good as far as if it's going to improve, it's a very good drug with least side effects to improve sperm counts.
All right. Thank you for confirming in such case, and thank you for yet another question. And one more. Okay, let's have a look. Do you have results in such case with letrozole in non-obstructive azoospermia?
That's a very good question, Anna. As far as the results go, the results depend upon how responsive they are to the treatment. But in general, we've had good results with the letrozole. Now, remember, when you talk about non-obstructive azoospermia, a good result doesn't mean they go to a normal sperm count. A good result means that we can get them to the point where they have enough sperm to actually go through an IVF process, or maybe have enough sperm for an IUI procedure.
Again, thank you so much. And someone again is typing, so I just want to have a look and wait.
Not a problem.
Yes, okay, let's have a look. There's a follow-up, okay? So here it is. So non-obstructive azoospermia, no, at a normal result. No normal result, but a spermogram for IVF without doing testing.
The answer is yes. I've had good results with the letrozole.
Okay. Thank you for the clarification. And of course, your follow-ups, Anna. I'm glad that you are asking more questions. And of course, I know that it's been useful for you. So we are very, very happy that it's helpful for you. And as you can see, thank you very much from Anna. And
very welcome, Anna.
I guess we will be again slowly finishing. So again, someone is typing. So we will be. We need to wait a bit. However, I would already like to thank everyone for joining us tonight, because it's definitely amazing to see that you are asking very detailed questions. That's why we are definitely here as well. And one more from Biso. Let's have a look. So I'm 51 and I did sperm freezing earlier. Do you recommend doing another round of freezing, say 5 years later, or is it not needed?
So I just want to make sure of the question. You froze sperm 5 years ago, or are you asking should you freeze sperm 5 years from now? You did freezing this year. Okay, great. I would say try to freeze as many. I would do another sample now instead of waiting, just because as you get older, the sperm quality and concentration will decline. So I would try to freeze as much as you can this year. And it all depends upon your goals. How many vials you freeze depends upon your goals in the future. But if you already have 7 or 8 vials of sperm frozen, that should be enough to any type of treatment you desire, inseminations or IVF. But if you're going to produce more, I would do it sooner than later.
Wonderful. Thank you so much for the clarification. And of course, your advice on that. Definitely useful again. And of course, there's a thanks from Biso for you right here. Thanks a lot. Okay. And before we finish, okay, because we are coming to an end, Dr. Thornton, anything you would like to add before I let you go, of course?
I think these are exciting questions. and I'm happy I was able to help. I think in all cases, from the questions that we're seeing, I think all of you will be successful. Anna, I think you're going to be fine with the letrozole. And I have a philosophy is if we can do things in a non-invasive manner to get to the same outcome, it's better to be non-invasive before we are invasive. And TESI is a very invasive procedure, so I would definitely recommend trying a letrozole for a few months and see what happens before you go to a TESI. And Bizzle, it's good that you froze your sperm. Depending on how many bottles of sperm you're frozen, I don't think you need to freeze anymore. But if you do want to freeze more sperm, now is the time to do it so you don't have the effects of age as you get older.
And as you can see, there's a smile from Anna for your...
Thank you, Anna. Anna made my day. I appreciate that.
Thank you so much. And of course, Biso, of course, thank you so much as well. And you have added, yeah, I can answer this for you actually, because this has been recorded, okay? So don't worry, you will be able to simply watch the recording, and it will be available tomorrow on our site. So, you know, I will be happy to send you a link. That's not a problem at all. So thank you everyone for all your incredible questions, for your incredible advice, of course, as well, Dr. Melvin. It's been great to have you here. And I just want to also again mention that you will have a chance to watch this again, as it is will be available. And as you can see, more thank yous are coming up for you right here. And of course, you will be able to find our webinar, this webinar, on my IVF Answers and YouTube channel. Tomorrow morning, it will be right there. And as you probably know, I hope, there are over 300 webinars on our site, so there are plenty of topics to choose from. And one more thing, if you would like to get in touch with Dr. Thornton and his team, and you can actually do it, you will be redirected to the website, and there is an option to simply contact Dr. Thornton, and I'm sure he will be happy to help you out as well. So don't hesitate. It's been great to have you here for sure, and I just hope we will have another option to cooperate. Okay, Dr. Thornton, thank you so much for joining us tonight.
Thank you so much.
Thank you so much.
Evening.
Have a lovely day, and everyone else have a lovely evening, and take care.
Bye.
Bye.
Bye-bye.